Bismillahirrahmanirrahim. Today we will have case quiz number 15. Case data: 35 years old female complaining of 6 months history of worsening fatigue. Worsening fatigue for 6 months history. With 3 weeks history of progressive shortness of breath and 2 weeks history of orthopnea and leg edema. Patient is known to have diffuse cutaneous systemic sclerosis for years, as the previous case, if you remember. GIT showed GERD, gastroesophageal reflux disease, which is treated by omeprazole only. Physical examination showed patient is alert, respiratory distress, temperature within normal 37.2, blood pressure within normal, pulse tachycardia 108 beat per minute, respiratory rate tachypnea 24 cycle per minute, body mass index obese with 31 BMI, oxygen saturation somewhat low 92% only, elevated jugular venous pressure, crackles at lung bases. Skin examination show diffuse systemic sclerosis with skin thickening on the face and the four extremities beyond elbows and knees. Sclerodactyly, lower limb edema till the knees. Laboratory investigations show serum creatinine increased 2.2. Cardiopulmonary investigations showed chest X-ray, bilateral pleural effusions, and diffuse alveolar infiltrates. Echocardiography showed generalized myocardial hypokinesis, and left ventricular ejection fraction is 20% only. So a severe deterioration of cardiac functions. Finally, ECG non-specific T-wave changes. So, which of the following is the most likely cause of this patient's clinical presentation? Is it cardiomyopathy or constrictive pericarditis or pulmonary arterial hypertension or scleroderma renal crisis? Which of the most likely complication for diffuse systemic scleroderma or systemic sclerosis causing this condition? The answer is cardiomyopathy. Cardiomyopathy. Educational objective of this case: to diagnose cardiomyopathy in a patient with systemic sclerosis. Discussion: the most likely diagnosis is cardiomyopathy in the patient with systemic sclerosis. Cardiomyopathy due to systemic sclerosis-induced coronary vasospasm and microvascular disease leading to a patchy myocardial fibrosis is the most common symptomatic manifestation of heart involvement in systemic sclerosis. Although accelerated macroscopic coronary atherosclerosis had been associated with other autoimmune inflammatory disease, coronary vascular involvement in systemic sclerosis is most often microvascular, with ischemia due to structural changes and recurrent spasm of small vessels. This results in contraction band necrosis, a pathological finding due to episodes of myocardial ischemia followed by reperfusion. This process may ultimately lead to patchy fibrosis resulting in cardiomyopathy and heart failure. Patients who have systemic sclerosis with symptomatic cardiac involvement have a poor prognosis, and the mortality rate is 75 within 5 years. So the 5-year survival rate for these cases is only 25%. This patient presents with evidence of fluid overload due to heart failure as seen in her physical examination and confirmed by an abnormal chest radiograph and echocardiogram suggesting diffuse myocardial dysfunction consistent with this cause. Infiltrative myocardial fibrosis and conduction abnormalities may be also contribute to the cardiac dysfunction, but are less common causes of systemic sclerosis heart disease. Constrictive pericarditis, on the other hand, is a chronic disorder resulting from inflammation and fibrosis of the pericardium with loss of elasticity and resulting non-compliance of the pericardium. Although it may be associated with connective tissue disease, this patient doesn't have specific clinical findings typically associated with constrictive pericarditis, such as pericardial knock or pulsus paradoxus. Furthermore, her echocardiogram show evidence of diffuse myocardial dysfunction and no evidence of impaired cardiac filling with normal ventricular function as would be expected with constrictive pericarditis. In constrictive pericarditis, the heart is normal, but it is compressed from outside, from the pericardium. Pulmonary artery hypertension is a common complication of systemic sclerosis and may lead to core pulmonal and primary right side heart failure. This patient's clinical presentation is more consistent with generalized myocardial dysfunction due to cardiomyopathy rather than right-sided heart failure. The kidneys are frequently involved in systemic sclerosis, with scleroderma renal crisis occurring in 10% to 15% of patients, especially the diffuse type. However, scleroderma renal crisis causes acute onset oliguric kidney disease with severe hypertension and often microangiopathic hemolysis and thrombocytopenia. Except for evidence of impaired kidney function likely due to heart failure, this patient clinical presentation is not consistent with scleroderma renal crisis. The key point of this case is microvascular cardiomyopathy is the most common symptomatic manifestation of heart involvement in systemic sclerosis and presents with heart failure. And finally, thank you very much for your attendance, and we will meet you in the next future with case quiz number 16. Wassalamu alaikum wa rahmatullahi wa barakatuh.